I'm Dr. Brian Blair. I'm one of the orthopedic surgeons here in the sports medicine. I'm here to talk to you about joint preservation and restoration, and we'll explain what that is. First, a little bit about who I am, right? Who's this guy talking to you? Helps to know. I was born in California. I grew up in Houston, Texas, where I lived until I went through high school. I went to undergrad at Furman University. I was recruited there and played college soccer for 4 years. After I graduated from Furman, I had the joy of playing professional soccer for 3 years, and then got smart and finally went to medical school, where I attended medical school at MUSC in Charleston. I did my residency in the Dallas-Fort Worth area. For orthopedics, it's 5 years. We do our residency training after medical school. And then we can elect to do a fellowship, which is an extra year of training after we do residency. And there's different fellowships. We have hand surgery and spine surgery and trauma and sports medicine and tumors. And so there's lots of pediatrics. There's lots of different sub-fellowships. And so some of us choose to do an extra year of fellowship training, which I did at the Stebbin Hawkins Clinic of the Carolinas, which is in Greenville. And there's another clinic in Vail, Colorado, where we train as well. And so I'm board certified in orthopedic surgery, but I also have another board certification in sports medicine. And so I'm married and I have 2 children, ages 6 and 3. And I've been in this area for 3 years. When I finished fellowship, I was practicing in Florence for 4 years, just up the road. Okay, so what is joint preservation? So I'm a sports medicine guy. I like to keep the joint you've got for as long as we can. That's the goal, right? I always tell my patients, and I see some familiar faces in here, the end of the road is a joint replacement. My job is to prolong that as long as we can. And there's a lot of different ways we can do that. And so this talk is to help you understand what is it. So the purpose of this is to help maintain and preserve your joint as long as we can. There are different ways to do this. We've got medications. I always tell my patients, you know, we have pills, we have shots, we have surgery, and we have therapy too. That's for Lance and our therapists that we have here. There's a reason we have therapists in-house, because it works. And that's a big component of preserving and maintaining your joint as well. So, you know, I'm an arthroscopist by heart. So arthroscopy is where we put cameras in the joint. And so a lot of what we do to help preserve your joint, we do through minimally invasive techniques. Arthroscopy is one of them. Okay, so the ends of your bone are covered in cartilage. Everything we talk about arthritis and joint preservation is geared towards maintaining your cartilage. Your cartilage covers the ends of the bone, and it helps act as a shock absorber. Believe it or not, your cartilage is 70% water. And as we age, that water content decreases and makes our cartilage more brittle, right? And therefore, it can break and it can crack. And that's how we grade arthritis. We use the term arthritis very loosely, right? We grade arthritis from grade 1 to grade 4. Grade 1 is where you have a little crack in the cartilage. Grade 4 is where you have the cartilage is completely gone and exposed bone. So the cartilage is very important. It acts as a shock absorber. It helps distribute stresses when you walk. Believe it or not, when you take one step, you put up to 3 times your body weight through your knee just standing here. When you run, you put up to 9 times your body weight through your knee. I mean, if you think how much you weigh, 9 times that amount goes through your joint when you're running or walking. It's pretty impressive. And your cartilage has these different zones. And this is a busy scientific slide, but it's this calcified cartilage layer right here. This is the one we talk about. When you have exposed bone, that becomes important later. So, you know, there's different kinds of arthritis. People say, well, why do I have arthritis? What kind is it? There's over 200 causes of arthritis, right? It's just the cartilage. What we care about is the cartilage is damaged. There's different. Most people have just general osteoarthritis. A lot of it's congenital, infectious. There's a lot of different causes. But they all do the same thing. They erode your cartilage and cause it to break down. This didn't come through on that screen. But that top one is just, it looks like crab meat. You can get loose bodies like that second picture. This picture is a good picture of cartilage that's worn all the way down to bone. You see that hole? And then this looks like just crab meat, right? That's all cartilage damage. And so, anyway, there's, we talk about different, things that cartilage does. It helps protect your joints. And so there's hyaline cartilage is a type of cartilage we're born with. Fibrocartilage, the reason I put the slide here, is just scar cartilage, right? Once your cartilage is gone, it's gone forever. Okay, your native original cartilage. Now, science is progressing, and that's the whole concept of joint preservation is the magic pill is how do we get you to grow native cartilage in your knee, right? We can't do that yet. We haven't figured it out. We're getting close. That's where all these other things come about, like stem cells and some of the stuff I'll talk to you about. But the goal is to get you to regenerate your own cartilage. Right now, we can't do that. We can get scar cartilage is the best we can do, which is this fibrocartilage. It's not the same cartilage you're born with, but as you saw that hole in the knee, it can fill in that hole. It fills in the pothole. So what hurts is that exposed bone. When every time you take a step or anything that rubs on that exposed bone hurts. There's a guy in California who's an orthopedic surgeon his name is Scott Dye, and he writes a lot about what I'm talking about. Well, he wrote an article. He had somebody perform arthroscopy on his knee while he was wide awake. It's crazy, I know. But he wrote a paper on what hurts in the knee. So he was wide awake. He had somebody stick a scope in his knee. He was watching it, and they went around his knee and just grabbed things, poked, prodded, and he would look, ow, that hurts, or no, that doesn't hurt. And he wrote this great article on what hurts in the knee. So pretty interesting and crazy, I think, too. So, there's, we can talk about medications, right? It's a simple way to start. We're all familiar with medications that we can take for inflammation, right? Because arthritis is an inflammatory process. We've got anti-inflammatory medications like Advil, Aleve, Motrin. All those are anti-inflammatories that affect an inflammatory cascade and help decrease inflammation. Then there's Tylenol. A lot of people confuse Tylenol with anti-inflammatory medications. Tylenol is not an anti-inflammatory medication. It's a pain reliever. It helps alleviate pain, but it does nothing for inflammation. Okay, so we're trying to protect the cartilage. Can we delay, minimize degeneration and pain? So we're trying to avoid traumatized, damaged cartilage, okay? So, a lot of it, I'll put the slide up here to remind people of their alignment, the way we're born, right? Most of us are born a little bit knock-kneed, right? And so what that tells us is if we draw a line from your hip to your ankle, where you bear weight when you walk. Most people bear weight on the inside part of their knee. So there are things we can do, like braces. We can prescribe people braces to help unload parts of their joint. So if you're bow-legged, we can prescribe braces that help unload the inside part of your knee and help change where you bear weight and help your pain. And then strengthening with therapy. Therapy helps. Motion is healthy for an arthritic joint. I tell all my patients that. No matter how bad your arthritis is, motion helps lubricate your joint and helps decrease pain and increase function. So here's our medications, right? Aleve, Advil, Motrin, all these help work on a certain enzyme that causes inflammation. That's the goal of the anti-inflammatories. Pills have side effects, just like anything, right? All these anti-inflammatory medicines are very acidic, and so if you have GI problems, you take those medications, they can cause ulcers, bleeding ulcers, and they're very hard on your kidneys, so they're not without side effects. And then, a lot of these anti-inflammatory medicines they've taken off the market now because of the cardiac side effects. And so our options for anti-inflammatory medications seem to be shrinking and shrinking and shrinking. I'm sure a lot of you remember Bextra, Vioxx. Those medications work great. I still have one pill of each that I keep just to but they work great, but they had cardiac side effects, and so all these black box warnings out, and so all these we're getting limited in the medications we can take, and their side effects are pretty significant. Okay, I'm sure I talk to my patients about oral supplements. glucosamine, chondroitin, all these things that are out there. I mean, you go in any of these stores, Costco, wherever, you see all these joint juice, everything, right? It's a multi-billion-dollar industry. The problem with the supplement industry is it's not regulated. Medications, drugs we take are regulated by the FDA, right? They have to go through scrutinized testing in order to get approved. Supplements, on the other hand, are not regulated. You could put dirt in a capsule and sell it as joint cure, and you don't know. Some of it's tested, but it's not a regulated industry. Glucosamine and chondroitin sulfate out there, there's a lot of science on this, some of it good, some of it not good, that glucosamine and chondroitin are kind of the building blocks of your cartilage. And so these medications help somehow nourish your cartilage, they think. The studies that are out there aren't great. I tell patients, try it. You know, don't take it for more than a month. Try it a few weeks. If you notice a difference, great. If you don't waste your money. But they can work, and patients do get benefit from it. I'm not knocking it. I just think, you know, you got to know if it works for you. Okay? It doesn't slow the progression of osteoarthritis, right? People with we grade arthritis mild, moderate, and severe. People with moderate arthritis, some of the studies show that it can decrease pain. It doesn't slow the progression, it somehow helps nourish the cartilage. And it doesn't regenerate cartilage. And then we get to injections, right? I tell my patients you can have steroid injections, right? A lot of you have heard of steroid injections. Steroid is a potent anti-inflammatory. It's like taking the medication and putting it right in your joint versus taking a pill. It works. These work great. Steroid injections have a rapid onset. You'll get better in 2 or 3 days when you get a steroid injection. It's safe to perform about every 3 months, the studies have shown. More than that, it can degrade cartilage. They tend to have diminishing returns over time. A lot of you have had steroid injections. You know, if one lasts 3 months, they tend to last less over time. But I have plenty of people that come in every 3 months and get their steroid shot and go on their way.
Is there a maximum?
Not every 3 months is the safe time frame, but I have patients that have been doing it for years. It tends to last less over time, though. You know, has been my experience with it. So steroid shots are usually the first line of defense. Very powerful tools. I use them all the time. They help us treat inflammation, treat arthritis, and so it's a good starting point. It's not a cure, it's just decreasing the inflammation in your joint. So the hyaluronic acid injections, viscosupplementation, we always compare it to WD-40 in the joint. And so these have been shown to decrease pain and increase function. It's a lubricant gel if you haven't seen this stuff. I compare it to putting mineral oil on your hands, right? It decreases the amount of friction in your joint when you do these shots. So it's meant to help decrease friction, help rough surfaces glide more smoothly over each other, and therefore decrease pain. So it acts as a lubricant and helps with shock absorption. So it helps distribute some of those stresses as you walk. So it helps induce protective cells via cytokines, and we'll get more of this later. Cytokines are cells that live in your bloodstream and other places that help stimulate other cells and help nourish your cartilage cells. PRP, how many of you have heard of PRP or plasma injections? Okay, so it's out there. What this is, and this is near and dear to my heart, I've been doing this for a long time. Your blood is filled with many wonderful things, some bad things too, but some very good things. Platelet-rich plasma injections has been out for many years. What we do is we just take your blood and centrifuge it and separate it. So we pull out the red blood cells, or one component of your blood here, and the plasma is the other component. The other area in between is a buffy coat layer. But the plasma is the stuff on top is what we like. And this plasma is filled with all kinds of goodies. This got a lot of press back in the Steelers in the Super Bowl, 2008, before that. Hines Ward sprained his MCL. They used PRP to help treat him, and then once it's on SportsCenter, Everybody wants to do it. So it gets in the mainstream media. So what platelet-rich plasma is where we take your own blood and spin it down and take the plasma out. And this has been around for many years. I started doing it probably 5 or 6 years ago. I was patient number 1 on myself. I had terrible plantar fasciitis and was reading up a lot about it and said, well, let's see if it works. I did it on myself and it worked well. Since then, I've probably done close to 2,000 injections. About 3 years ago, some studies came out looking at PRP injections for treating arthritis, because we always wondered what, this works for soft tissue stuff, tennis elbow, tendonitis. Steroid works, but there are certain areas in the body we don't like putting steroid because it can cause tendons to rupture. Achilles tendon, patellar tendon, we don't put steroid in there because it can weaken tendons and cause them to rupture. It's a negative side effect of the steroid. So what if we had something that, helped do that, but didn't have the side effects? And that's where the PRP comes in. So we like to, the way we think and process is evidence-based medicine. If we're going to do something, we need to know it works, and it needs to be proven scientifically that it works before we start using it. So when this first came out, there wasn't a lot of science behind it. The science is building, it's not great, but the studies for arthritis were level 1 studies. In our world, a level 1 study is the best you can get. It's a double-blind, placebo-controlled study, right? You get a treatment and you get a different treatment, and we follow you over time to see if it works. And so the studies for arthritis were the best studies you can get and showed that the plasma injections were clearly better than steroid and clearly better than the gel shots in some of the studies. So the only problem with this now is insurance doesn't pay for it, but eventually it will.
How long does it last?
I've been doing it steadily for about 3 years. The longest patient I've had that I did it in, I did a total knee on one side, and these are people with severe arthritis, mind you. This isn't mild arthritis. These are bone on bone. I've done some pretty significant arthritic people. On average, the studies, it's about 6 months. I've one as long as 2 years, and I've done lots of them. I can count on my hand the people that got probably less. I tell people to quantify their pain relief. 0 to 100%. 100% is pain-free. And everyone that comes in, how much relief did you get? Quantify it. A lot of people at 75 to 100%. I mean, significant sustained pain relief.
Did you mention this was not Medicare approved?
Not Medicare approved yet. There's a lot of studies coming out now, and there's a lot of data, and it's, all things being equal between the steroid shot, the gel shot, and this, I would do this. Knowing clinically what I've seen so far, so what does it cost? I'm not trying to sell, by no means am I trying to sell this here at all. And I called before I did this, so when I started doing it, I said, I'm going to do 50 patients, I just want to do it and see if it works. And I was number 1, right? This was for just soft tissue stuff. And then by 20, I was like, this works. I did the same thing for these arthritic joints. And I called around, just polled people all over the country. I heard as high as $3,000, as low as about $750. On average, it's about $500. I know there are people around here charging $2,500 a shot, right? I mean, it's the studies that were out, it was 1 shot a week for 3 weeks for arthritic joints, which is how I do it. But it's a very powerful new tool that we have, right?
What's the concept behind why that would work on?
We don't know. The studies that are out, honestly, there's a lot of science behind this. The truth is, we don't really know yet. We think there's a bunch of stuff in your plasma, growth factors and healing factors and cytokines, cells that help stimulate other cells to do good things, whether it's decrease inflammation, help grow scar cartilage, help nourish the cartilage cells you have. We don't know. I tell people, we don't know, but the proof is in the I wasn't going to do this, much less charge people for this unless I knew it worked. And
So if you're bone on bone,
yeah,
that will help.
I've seen it help people, yes. Is it a cure? No. Is it the end-all be-all? No. It's another tool that we have. It's another, I always start people with steroid, and if that doesn't work, we'll try something else. And if the people I do this in are people who've had everything, who are looking for something else, who aren't ready in their mind yet to have a joint replacement.
You have a blood transfusion and large amounts of blood, or plasma,
Right.
a lot of plasma, several pints. Would that have any effect on it?
No. We just, when we draw your blood, we take 10 cc's of blood out and spin it down and get about 4 cc's of the plasma.
So do you do the withdrawing, or you have a?
No, we do it here. I don't do it myself, but I could. But no, we have nurses that are much better at that than I am. But again, I'm not here to try to sell this. I'm here, it's another very powerful tool that we have. And you all hear about stem cells and things like this. Well, that's another, this is a precursor to, stem cells are cells that we all have within our marrow that are precursor cells to every cell that we have, right? It's the little cell, and then those cells differentiate and become whatever cell you can think about: cartilage cells, ear cells, skin cells, organ cells, right? And so we don't know exactly how this works, but clinically, I've done a lot, and you ask people, do you get better? Yes or no, and so.
Do you withdraw the blood and inject it the same day?
Yes. And I could do a whole talk on this by itself. I contemplated doing that. I've got a whole talk. I mean, this is neat stuff. And so this is one component of it.
On
So
average, how many shots does one have to have?
usually I do one a week for 3 weeks. And then it's a slower acting process. A steroid shot, you're going to get better in a few days. Plasma injections, it's very subtle. I've had I did an anesthesiologist at the hospital who was a naysayer. That stuff doesn't work. I heard it. And so he's got terrible arthritis, and I did 3 shots in him. And I didn't hear from him for 6 months. Well, that usually means they went somewhere else or they're doing well. And so I get a text from him, 5 months later saying, oh, I'll be dang. And so he's back for another round. He's doing it again. So the cell on it is your own stuff. Right, we're not putting anything foreign in you. We're taking your body's own ability to heal itself and taking advantage of that. And so we're using your own stuff. The side effects are minimum. I haven't had any, other than you get an injection and it hurts and stings a little bit, but it's not bad. But the side effects that we know of are minimal. It's convenient. Really, we can do it in 30 minutes or less. So does it promote healing? Who knows? We don't know. But I tell people it's cheaper than a joint replacement, and if it gets you 6 months or more relief, that's good quality of life. But all the initial evidence so far, the studies that have been done are good and are very positive. And so there's more data coming.
Which joints do you use that for?
Any one of
Does it
them.
just need any?
Anything. I've done knees, ankles, elbows, shoulders. All your joints are covered in cartilage, and I don't, that and soft tissue stuff. We use it on a lot of stuff. It's really neat. So now we're talking, okay, those are pills and shots, and then what are our surgical options? So I do a lot of arthroscopy, where we can put a camera in your joint and clean things up. And what can we do surgically? Well, one of the first original things we do is called microfracture. So if you've got an area of cartilage, it's hard to see here, it's worn down to bone, right? That cartilage is gone. So we need to do something to help this isolated lesion. That bone, when it hits, hurts. So if we can fill that pothole in somehow, we'll decrease your pain. So I tell people the cheap, easy way to do is what's called microfracture. The place I did my fellowship, the guy that invented this. So what we do is we drill holes in the bone. And when you drill holes in the bone, see all that red stuff? That's blood. That's what we like to see. Blood filled with good cells will fill that in. This is an after shot, and it's hard to see, but you can see that hole filled in. It fills in with scar cartilage. It's not the same cartilage, but the pothole gets filled in and decreases the pain. So it's that fibrocartilage I talked about, the scar cartilage. That's what it fills with. So microfracture is a very powerful tool. It works, it's proven, it's been studied, it's inexpensive, it works, and it's tested over time.
What's the recovery?
So when you have microfracture, depending on where it is, right, in your knees, if it's a weight-bearing joint, you can't walk on that joint for 6 weeks. You can move it. The motion actually helps stimulate car cartilage growth. We don't want you walking on that area because it'll break that clot up. We want that clot to fill in and harden. So usually if it's a weight-bearing joint, you don't walk for 6 weeks, but you can move it. And it's difficult. It's a pain not to walk. Think about not being able to walk on a... Right, and it's a pain, right. It's a pain when you do. So the goal, microfracture works. It's great. And we can do this arthroscopically, you know, small little holes. We can go in pretty much any joint. I do arthroscopy of the shoulder, elbow, hip, knee, and ankle. And so we can go in joints with these little cameras and do this through small incision. So another tool that we have. So there's cartilage restoration. So there's some other stuff on the market. And that microfracture works for isolated, probably dime-sized lesions or big. I've done it in bigger, but it's for, if your whole knee's arthritic, we don't drill holes all over your knee. It doesn't work as well. Now it can help, but studies have shown it doesn't work as well than it does for smaller, isolated little lesions. Those work great. Then when the lesion gets bigger, as you can see here, right, this is a big, huge area. There's some other stuff on the market where we can sew live cartilage cells. That's what this is. It's called autologous chondrocyte implantation. This is another surgical procedure we use where you go in and you biopsy your own cartilage. It requires 2 operations. We send that off and they harvest the cartilage cells. And you come back at a later date and you put the cartilage cells in there and you sew them in the knee with a patch of tissue in hopes that you're getting some cartilage cells to regenerate. This is really expensive compared to microfracture where you're just drilling holes, and the results are fairly similar. I do a lot of microfracture. I don't do much of this at all just because of cost factors and other factors. I think it's...
That's the so-called stem cells?
This isn't stem cell. Stem cell treatment is kind of like the PRP, right, where you're taking cells from your marrow and injecting them into your knee. Same concept as the plasma injections. But no studies have shown better clinical. So what we care about are clinical results. You can do all these things, but do you get better? Does your pain go away? That's what we care about, right? That's all that matters. You have pain, can we make your pain better? Can we make it go away? That's really all that matters. And they're studying all this stuff, but no one's really proven that one thing makes your pain go away better than another. Like the PRP, there's a lot of different types, commercial products, ways to do it. Some people say, well, you need a real high platelet concentration in there. And then some say, well, you don't need a high platelet concentration, you need this or that. But no one said, well, one produces a better clinical result than the other. Like stem cells versus plasma injections. Stem cell injections, and you hear that, those are expensive. Some people those are $5,000, $6,000 for a shot that may or may not work, right? And no one's said the clinical data is better than one over another. I've kind of done it the same way for 5 straight years, and until it doesn't work anymore, I don't see the need to switch. So no science has proven me to switch, I should say, yet. So this is another thing we can do. Then we can go steal cartilage from other areas of your body and plug it in areas that you have defects, right? So we can go in your knee. There are certain areas of your knee where you don't really need cartilage, small little areas. And we can take plugs of those cartilage out and go take them and fill in cartilage defects all over your body. We do this a lot in the ankle. I've done it in the knee before, but you can see this lesion here, and then you can see this plug of cartilage, you go steal it from somewhere, or you can use donor cartilage from a cadaver, and then you fill in these little holes. It's got bone with a little cartilage plug on it. And so we can use cadaver graft or take cartilage from elsewhere in your body to fill in those holes. So that's another thing we can do. And that's what the plug looks like right there. You see this little plug? It's got cartilage on the top and bone. So you fill in the bone, that bone grows in, and it's got native real cartilage on it. So those do better for a little bit bigger lesions. Again, we can't do it all over your knee, but instead of a dime size, quarter size or a little bit bigger. And then the end of the road, right? If none of this other stuff works, right, we're not going to, I always tell my patients, we're not going to, if you're having pain and you're miserable and you have arthritis, we can still replace your joint, right? That's the end of the road. To me, that's the last option. But we can still replace your knee, replace your hip, replace your shoulder. We can do joint replacements. It's a good operation. It's tried and true. We've done lots of them. But my goal is to keep the joint you have for as long as we can. And these are some of the tricks that we use to do that. And it's changing constantly. All this stem cell, and it's just, you know, the technology with this is where this joint preservation is a big deal, because people are nervous about joint replacements. It's a big operation, right? And if you can do some other stuff to preserve your joint, it's a big deal. Yeah, one more question. Thank you.